people are still joining the session. I am Professor Gina Higginbottom. I'm Emeritus Professor of Ethnicity and Community Health. I'm also a member of the Academic Advisory Group for the Race and Health Observatory and a member of the Maternity Action Group. And I'm absolutely thrilled to be hosting the session today with my colleague, Dr. Ikhile, as part of the University of Nottingham Black and Minority Ethnic Staff Network's schedule of events for Black History Month. We are absolutely delighted that we have such a high profile and accomplished guests to converse with this afternoon. I am very pleased indeed to welcome Dr. Habib Naqvi, Director of the NHS Race and Health Observatory, to engage with us this afternoon on this immensely important and critical topic, that of race and health inequalities. I'm going to spend a few moments introducing Dr. Naqvi to the audience, and whilst I do that, perhaps, Maria, you could upload the infographic produced by the Race and Health Observatory so that perhaps the participants could have a few moments to reflect upon the current landscape in relation to ethnic health inequalities in the UK. Dr. Habib Naqvi, as Director of the NHS Race and Health Observatory, leads nationally on identifying and tackling ethnic health inequalities. He joined the NHS in 2001, managing large public health research programmes in the southwest of England. He also spent a number of years working at the Department of Health and Social Care, where he led national equality and diversity policy, including on the health sector's response to the UK government's review of the public sector equality duty. He joined NHS England in 2013, where he directed the development and implementation of the National Health Equity Programmes. Habib volunteers as a trustee of the Mary C. Cole Trust and was listed in this year in the Health Service Journal's 80 most influential people in health, and in its 2021 top 50 Black, Asian and minority ethnic leaders. He previously reverse mentored the Chief Executive of the NHS, Sir Simon Stevens, and was awarded an MBE in the 2019 Queen's Birthday Honours for services to equality and diversity in the NHS. We warmly welcome you, Habib, to the University of Nottingham. Thank you for accepting our invitation.
Thank you for inviting me, Gina. It's an absolute pleasure to be here today.
Good. And I'm going to hand over to my colleague now, Dr. Ikhile and Habib, to open up the conversation. And I should let the audience know that you can post further questions in the chat box. And towards the end of the session, we will try to summarise some of your questions. And if we have time, ask Habib to kindly answer these questions. I would also just like to mention that Habib does have a Twitter account, and he is Dr. H. Naqvi on Twitter, if anybody would like to be in contact with him. So colleagues, now the floor is yours.
Thank you very much, Professor Gina, for that warm introduction. And thank you very much, Dr. Naqvi, for honoring our invitation. We're really glad to have you here. Thank you everyone for joining us. We're happy to have you here as well. I think it's important to mention today that you could use the reaction icon. You find them on the toolbox at the top of your Teams. We'll be taking questions today. Most of the questions today have been submitted by the BME staff network. And if we have time at the end of the conversation, we'll also take questions from the chat box. So to save time, we'll just start with the questions, if that's okay. So Dr. Naqvi, what would you say the main priorities of the RHO are? What are the main objectives of the RHO?
Great, thank you. Well, the NHS Race and Health Observatory was announced last year in terms of its establishment. So I have to say, the idea of having a observatory or a body that looks at focusing on tackling ethnic health inequalities has been around for a number of years, and it wasn't until the BMJ special edition last year in February 2020 on the topic of racism in medicine that a very strong and robust case was put forward for the establishment of the observatory, and it was established thereafter. The key aims or the kind of the specific areas of focus for the observatory include looking at some of the long-standing issues we have around ethnic health inequalities and racial bias within healthcare and within this country, including, of course, on maternity, on mental health, on looking at, of course, over the last 18 months, as we have been on COVID-19 and the disproportionate impact upon ethnic minority communities and staff, looking at some of the racial biases we have within medical devices, and looking also at data, digital, and of course, partly due to the pandemic, the move towards digital healthcare. And what does that mean for our ethnic minority communities in terms of reducing rather than increasing health inequalities? We're also interested in supporting the healthcare architecture as it develops and as it kind of refreshes over time, to make sure that ethnic health inequalities and race inequality is kept at the forefront of those organizations' thinking and behaviors. And then finally, we also have a work stream which looks at stakeholder kind of engagement and global health and global working as well. And that's about what we know within the observatory, is that we cannot focus on this, a very important topic and agenda, without engagement with our patients and communities that's both sustained and it's meaningful over time rather than being tokenistic. And that's engagement not just within our own borders, geographical borders, but with race and health experts that we have pulled together from New Zealand, Australia, South Africa, Guatemala, North America, as well as Canada, and of course in the UK, looking at some of the common challenges, but also focusing on some of the common solutions to those common challenges as we move forward on this agenda. I guess what those work streams do is enable us to focus on some of the deep-seated health inequalities that we know of within this country and that we've known of for decades. Secondly, those work streams enable us to be reactive and responsive to emerging issues, as we have been with regards to COVID and in particular the vaccine. They enable us to make sure that this agenda is at the forefront of leaders' minds and it doesn't become kind of a golden thread through everything, whereby it doesn't become anyone's specific business. And they also, these work streams enable us to make sure that the work we do is absolutely embedded within co-production and within engagement and within cutting edge insight and evidence base, not just from within our own country, but globally as well.
Okay, thank you very much for that, Dr. Habib. So if we have effective mainstream services, why do you think the RHO is necessary, the Race and Health Observatory?
Yeah, that's a very good question. Now, we know that racial inequality is a global system-wide issue.
That's right.
That requires a global and system-wide response. And we know the fact that when you look at service provision, you look at access and experience and outcomes to healthcare, that there are differences in a range of different areas, whether that's genetic counselling, whether that's artificial intelligence, whether it's maternal health. And we also know that these disparities are set against higher prevalence rates of specific diseases and conditions that we are all too familiar with. Specific cancers amongst ethnic minority communities, higher prevalence rates of diabetes and cardiovascular disease, not to mention mental illness and issues around maternity. And what we've seen over the last 18 months is the disproportionate impact of a pandemic upon our communities. And I guess the NHS is perhaps the most visible expression of a shared social contract between people, and we're very lucky in this country to have a healthcare system that's free at the point of access. But to be proud of our NHS is not to be blind to some of its imperfections. And some of those imperfections are the stratification, I guess, that we see in access and experience and in outcomes. And so there is a level of urgency for us to focus on this agenda. And I guess, in a way, our country and our healthcare system should be well equipped to deal with that level of urgency. We've got a long history of migration in this country. We've got large and growing ethnic minority communities. We've got robust legal frameworks in the Equality Act and the Health and Equalities duties, and we've always had very good investment in healthcare research, and the Oxford vaccine is just one example of that. But at the same time, it can be argued that our attempts as a country, as a healthcare system over time to tackle these long-standing issues have been somewhat fragmented, costly and confused. And whereas think tanks and commissions units have been set up to focus on this area, arguably in general they focused on kind of looking at surface level issues and kind of academic exercises of data collection, rather than focusing on what I call the causes of the causes around why is it that we have this level of stratification in access and experience and outcomes. So there is a need for a independent body such as the Observatory to hold up a mirror to the organisation and be a excuse remover to some of the challenges that we have seen over time. And that's why, hats off to Sir Simon Stevens for establishing the Observatory, but also hats off to Simon Stevens for not establishing it within NHS England as an organisation, because that would have been the easiest thing to do, but to have it as being independent so that it can actually hold up that mirror and it can have the confidence of the people in the objectivity of the work that we do.
That you do. That's good. Thanks a lot for that, Dr. Naqvi. You've spoken about the disproportionate impact of the pandemic on the BAME community. How would you say that institutional, systematic and personal racism has impacted on the BAME people's experience of COVID-19?
COVID-19 has been a wake-up call for us, and it has, and you will have heard this phrase quite often over the last 18 months or so, about COVID-19 shining a spotlight on the health inequalities that have existed for some time. And what I guess we cannot do is we cannot escape the harsh reality of the disproportionate impact that COVID-19 has had and continues to have, because COVID-19 is not yesterday's challenge, and the disproportionate impact that COVID-19 is having on our ethnic minority communities is not yesterday's news. this continues. It continues today. We cannot escape that harsh reality, but what we can do is we can learn lessons from the past, from the recent past around COVID-19, and take things and progress things forward. So we know there's a lot more work to be done in terms of engaging in a meaningful and sustained way with our communities with regards to interventions, and of course with regards to building trust with our communities around interventions, not least the COVID-19 vaccine. And trust is a critical element. And my colleague within the Observatory, Professor Kevin Fenton, talks about trust as being something about truth told consistently over time. And we need that level of trust in people, and people need to have that level of trust in our institutions and our organizations, our governing bodies, and in the interventions that we put forward. And that's important in terms of comms and communications and media messages. It's important in terms of how we co-design, co-produce interventions and services and roll them out, and kind of the feedback that we get on that. So it becomes an ever-learning process over time.
Thank you very much for that. I think this is kind of related to the previous question. So we've spoken about the disproportionate impact on the BME community. We also found that from data, more BME health professionals died during the pandemic. Why do you think this was the case?
Well, I think that goes back to the causes of the causes, essentially. Yes, we know from reports that that a higher proportion of ethnic minority died from COVID, and yes, we know from those reports that some of the reasoning for that has been that ethnic minority people are more likely to be front-facing roles within society in terms of the jobs that they do. We know that other factors have been listed, such as comorbidities. Ethnic minority people are more likely in general to have comorbidities. And of course, the other point that was raised was living in multi-generational households. Now, those are the reasons that have been given. But if we start to look at the causes of those, we start to think about why is it that ethnic minority people are more likely to be in front-facing roles? Why is it that they are more likely to live in multi-generational households or have comorbidities at kind of a higher level than the general population? And when we start to think about those causes of the causes, and when we start to think about the role that society plays in the life chances that people have, and of course the privileges and the lack of challenges that some people have compared to others within society as a whole, then we need to kind of understand and begin to think about some of the solutions to some of the inherent problems and challenges that we have within society as a whole. So those are some of the kind of the things that we need to focus upon, and healthcare and the NHS, of course, has a role to play in that. But the NHS and healthcare is not the only enabler for equity, but it has a significant role to play. And that's why looking at racial inequality as a global, system-wide structural issue that requires a global and structural response is absolutely critical, because it's not just health, but it's also housing, it's also education, it's also the other determinants of health, and of course as Professor Sir Michael Marmot says, looking at the causes of the causes, as it were.
Okay, thank you very much for that. I like that phrase, causes of the causes. I'll definitely remember it after today. We know that there are a lot of cultural barriers among the BAME community, and this in particular has led to a lot of negative experiences in access to healthcare. This has also led to suspicions among the BIM community. And for this reason, a lot of members of the BIM community have refused to be vaccinated. How do you think we can encourage them to be vaccinated?
Yeah, it's a pertinent and timely question, particularly as we have come through the different phases of the pandemic, as we've come through the initial rollout of the vaccine program, and as we now have the booster jab and head into the winter. It goes back to my point around trust, and having the level of trust amongst our communities is absolutely essential. What we do know from a history, I guess, is that having a one-size top-down approach will not suffice. A top-down, one-size-fits-all approach has, in effect, derailed countless well-meaning health initiatives in the past. And in the context of vaccine implementation, it does risk leaving some communities behind. And that's why policymakers beginning to think about how they can learn lessons from the past and adopt approaches that give communities a voice and give communities a significant role in the co-design of implementation of interventions is absolutely necessary. I guess at the same time, we need to remember that it's not just our ethnic minority communities that are showing a level of mistrust or lack of confidence in the vaccine program, and of course, they should not be demonized for approaches that may not have included their voice in interventions early on. And related to that is the point that there are no hard-to-reach communities. It must be about us, about the system that's able to reach out. And I think back to the beginning of the pandemic, right at the beginning, January, February 2020. I have to think where I am in the calendar these days. Right at the beginning of the pandemic, where we knew, working in the system, that when an organization or a system moves away from working in the norm to working in an emergency situation, as we were beginning to, that issues around equality, diversity, inclusion and equity would go out of the window. We knew that was going to happen. What we didn't know was how quickly that would happen. And I was kind of surprised on how quickly that happened. And issues that arose thereafter around making sure that there is representative decision making in interventions at organizational level within the NHS, and I guess beyond the NHS, making sure that when we're bringing back staff to work, newly retired staff from the NHS in particular, to work on the ground, that we're taking account of representation there. When we're setting up new organizations and new super hospitals, that there is appropriate levels of representation within the leadership and the workforce of those organizations. When we're looking at issues around healthcare staff and protective equipment, PPE, when we're looking at the processes that we put in place to encourage staff to take the vaccine when that came around, that all those matters, and in all those interventions have inclusion at their heart. It took a while, I believe. I think the NHS is getting there and did a lot of work to get to that stage. But simple things like, setting up vaccination hubs. And I remember tweeting out very early on tweeting out very early on this year around ensuring that it's not just your conference centres, your indoor bowling clubs and your horse racing venues that are vaccination hubs, but that we take into account and we utilise Black churches, temples, mosques, synagogues, because those are well positioned and structured buildings where you can have vaccination centres and vaccination hubs, and putting that message out, I think very early on we did enable the NHS to build on that kind of that level of advice.
That's right. Thank you very much. You've spoken about important interventions that have been made with regards to access, but I'm also aware that other than in access, there are issues around conspiracy theories around the vaccine also that may have prevented not just members of the BAME community, but a lot of other people from getting vaccinated. And so I think it's commendable what you've done with access. Okay, so at the beginning of the session, there was an infographic that was put up. I recall that one of the areas that the RHO focuses on is maternity. The infographic says, for that, I think that's even the very first icon you see there, is that Black women are 4 times more likely than white women to die in pregnancy or childbirth in the UK. So that's what it says. Why do you think that maternal mortality is so high for Black women?
Well, we're lucky enough to have Professor Gina working with us on that topic as a expert in that field, and of course we know that there are ethnic disparities in maternal care, and yes, we do know that Black and minority ethnic women are, I guess, paying with their lives for the lack of action on racial bias in this area. And that's why maternal health, or the lack of it, is one of the starkest examples of racial health inequalities in the UK. Those figures are absolutely shocking. Today, in 2021, for Black women to be up to 4 to 5 times likely to die during pregnancy, childbirth, or thereafter, and Asian women up to 2 times more likely, is are statistics that we should not have to talk about in this day and age.
That's right.
And that's why maternal health and neonatal health are one of the key priorities for the NHS Race and Health Observatory. And we are beginning to focus on looking at some of those causes of the causes around that. And so there is, I guess, that level of urgency for us to focus on that. But as I mentioned before, that racial stratification and access, experience and outcomes, is pertinent here as well. And when we take the example of, say, I don't know, let's take an example of endometriosis, for example. Black women are less likely than white women to receive a correct diagnosis, timely diagnosis of that specific condition. And whilst there may well be subtle cultural differences in the way that different ethnic groups present their symptoms, and we know that from I did some research 15 years ago in Bristol looking at subtle cultural differences with regards to chest pain and presentation of angina, for example, and we know that there are cultural differences in that. What there also is a level of bias. There's bias in clinicians' assumptions, for example, in relation to pain management between different cultures. There's bias in policies and processes that we have in place within the healthcare system, and there's bias in the evidence upon which interventions and services are designed and rolled out. Now, just one example of that is some work that we did within the observatory just a few months ago, which was looking at racial bias in pulse oximetry. So the little clips that they put on your fingers, very usually when you're in hospital, to measure the level of oxygen in your blood, in your body. What we know is that the darker the color of your skin, the less accurate in general the reading is likely to be. That's not to say, and this is a very important point, that's not to say that pulse oximeters are bad and we shouldn't be using them. They're a very vital, essential tool and medical device. But we need to be careful around the readings, particularly with people with darker skin. And the reason for that is the inherent bias. And that inherent bias comes from, for example, if you look at the clinical trials upon which these devices are designed, now those clinical trials are less likely to be representative in terms of the research participants.
That's right.
Than what we see across the whole of society, and then that then leads to the development of devices that may not be fit for purpose for the diverse communities that we are here to serve. And pulse oximetry is just one example of that. But we put out a very clear, rapid review of the evidence base earlier this year, with very clear recommendations for change for some of the regulators and for NHS England. And we're pleased to say two things really. One is that the NHS has updated its guidance on home pulse oximetry and pulse oximeters in general as a result of our evidence base report. And the Secretary of State for Health and Care, Sajid Javid, at his Conservative Party conference speech just a couple of weeks ago, mentioned this as a key point, one of his key points, I should say, around racial bias in medical devices and how we need to be looking at some of that to do that. So I guess going back to your question, this is about looking at those causes of the causes again, and that's kind of seems to be a common theme here for us. And if we can begin to do that with regards to maternal health, and not just maternal health, but neonatal health as well. As I said before, we're lucky to have Professor Gina with us on that advisory group, a group that's being led by Professor Jacqueline Dunkley-Bent, the Chief Midwifery Officer. And we are looking at those kinds of racial biases. The APGAR score, for example, which looks at determining whether a baby is healthy or not minutes after its birth, and has a list of things to look at, one of which is looking at the colour of the skin of the baby. And of course, that APGAR score has been around since 1952, so a very long time, but perhaps not based upon a diverse population that the NHS is now serving compared to what it was serving back in 1952. So we are beginning to think about and work upon and focus on some of those issues that will help us, hopefully, to reduce some of the inequalities that we see in maternal health.
Okay, thank you very much, Dr. Naqvi. We have a few questions to go, but we'll just take a couple from the chat box, if that's okay. So someone has asked that in the introduction, it was mentioned that you reverse mentored Lord Simon Stevens. So she says that they've just launched a call for reverse mentoring here at the University of Nottingham. Do you think it's worth doing? What would you say has been the impact of the relationship, and what does this mean for EDI or racial health inequalities in the NHS?
Yeah, that's a really good and important point. So the first thing I'll say, and she may be listening in on this, is my eternal thanks to Professor Stacey Johnson from the University of Nottingham, who has been my go-to person with regards to reciprocal mentoring, and who, in my opinion, is the guru for reciprocal mentoring across the UK, and is doing some fantastic work in this area across the NHS specifically. My reciprocal mentoring with Simon continues to this day, and we've been doing it for nearly 2 years now, I guess. And one of the things that Professor Stacey Johnson said to me when I talked to her about the idea of mentoring with Simon was that she said to me that it's not going to be an easy thing, because somebody like Simon Stevens, people do not know Simon Stevens, but he's a fantastic advocate for racial equality and equity, has worked across the globe, and is perhaps the only leader that I know that has come in to his role talking about race and doing something about race, as he did in 2014, and leaving his role as he did in July of this year, having just set up the NHS Race and Health Observatory, and in between those 2 points, absolutely focusing on racial equity. So in that sense, it wasn't going to be an easy gig for me, but something that I learned a huge amount from Simon around how he works, the kind of for somebody that's got a brain the size of a I was going to say small but a large planet, you know, how he strategically works with colleagues, with senior leaders, with politicians, with governments, as well as a day-to-day kind of working kind of thing. And I'm hoping that Simon will have learned from me about how it feels to be a ethnic minority person working in the NHS. With my background, with me being second generation, you know, my father coming here in 1956 with nothing but kind of a suitcase, an address on a piece of paper, and probably £5, I think he said, equivalent of in his pocket. You know, and the struggles that generation has had, the Windrush generation has had, and how they've had to, and we continue to now work twice as hard just to get half as far. And you know, those issues that Simon took on board with a huge amount of humility and you know, with kind of listening with empathy on those. I always go back to a quote in a J.R. Tolkien book. Not that I read J.R. Tolkien that often, but in one of his books, it's written that all we have to decide is what to do with the time given to us. Those people that decide to focus on these issues, including through interventions such as reciprocal mentoring, are people that are spending their time wisely. And I say that because of the evidence base around getting this right, not just for ethnic minority people, but getting this right for the whole of the population. One thing I think Stacey would probably want me to say is that the reciprocal mentoring, and I believe this as well. So it's not just Stacey, but I do believe that reciprocal mentoring is fantastic if that pairing is done appropriately. Otherwise, you know, otherwise it can be potentially detrimental to either or both parties. So that pairing needs to be focused on, and that's something that Stacey kind of honed into me very early on as well.
Thank you very much for that. It may interest you to know that it was Stacey who asked the question.
Oh, was it?
Yes.
Thank you, Stacey.
Yeah, well, thank you very much. Okay, I'll take the next question in the chat. I'm just going through the questions in order that they appear in the chat. It says here that what messages should we amplify as priority? How can we integrate these across transdisciplinary research and education?
Yeah, that's a good question. A lot to talk about there. I think for me, there's a fundamental thing here about people making sure that people and organizations have their moral compass pointing in the right direction, focusing on what we need to focus on. And some of that is looking at some of the inherent issues around the whole agenda of racial inequality and why that occurs, and the impact that has continues to have on individuals. And the other point around that, I guess, is how this agenda should not be the burden for those that are most affected by it. You know, everybody has a role to play in making sure that there is equity, and not just based upon the moral argument, but we have a whole range of different cases for achieving racial equity, not least for the people that we're here to serve, whether we are researchers or we are doctors or nurses, or whether we are teachers, you know, across the whole spectrum of society. We know that, you know, getting this right for our minority individuals will kind of raise the boat, raise the boats for all, and will have a positive impact across the whole of society. We know that from a financial perspective, we know that this will lead to levels of efficiency. In the NHS, for example, we asked the King's Fund to do some work for us just a few years ago, and they found that if you engage with the minority staff, in particular, it got very technical, but an increase in kind of 2 standard deviation points of engagement can lead to a hospital saving on average £1.6 million a year. Wow. And if you times that by the 230 odd hospitals that we have across the country, that's a lot of money that the NHS can save just by engaging with its minority staff, and money that can be diverted to where we need it to be diverted. So there is a huge amount that we can do and that we must focus on, but we mustn't be distracted from the core mission, and that means not getting as the director of the observatory, I'm very conscious that I should not be getting involved in or caught up in culture war around these issues, but actually keeping my focus absolutely on what the observatory has been set up to do, and that's to remove excuses, focus on the key issues around reducing ethnic health inequalities.
Thank you very much for that. I like what you said about everyone needing to get involved with ensuring equity, racial equity. It's everyone's job, and that's really important. Thanks a lot. I'll just move on to the next question, if that's okay. Someone's posted here that disproportionate impact of COVID-19 on minorities is huge in and of itself, but remote access to GP services is thought to have left ethnic minorities at a greater disadvantage in other non-COVID-19 health issues. So looking outside of COVID-19, has this been looked at? What do you think may have to be done, especially as we stare at a possible further COVID-19 related restrictions?
Yeah, it's a very timely question, and it's something that's at the forefront of our minds. There is, as we know, an elective backlog of care across the NHS, but we also know that there is a public health backlog as well, and that includes the kind of the missed hypertension appointments, the missed diabetes clinic appointments, and these appointments and these clinics that relate to conditions and diseases that disproportionately impact upon ethnic minorities. So when you think about stroke, hypertension, when you think about diabetes and cardiovascular disease, we know that those ethnic minority people are disproportionately impacted. So what we are thinking about doing and trying to get our hands on timely data in order for us to ascertain where we are with regards to what's happened over the last 18 months in terms of kind of missed appointments and missed interventions. What will that mean for us in the short to medium and of course the longer term as well? We're in the business of reducing ethnic health inequalities. What we want to do is make sure that the systems, organizations and bodies are supported and in a position to have the evidence base around which they can base their interventions. So that's absolutely critical for us to look forward to. What we don't want is that kind of increase in inequalities. Now, the related point I think that you mentioned in the question was around digital health as well. And as we, one of the things that the pandemic has done is speed things up in life. Sure. We see that in the workplace. We see that obviously having this particular conference online has led to that level of efficiency. There's no excuse very often for people to join meetings and conferences and events. When it comes to healthcare and healthcare delivery, we know that there is a move towards digitalization and to remote, for example, remote consultations, etc., which in one way is fantastic, it's cutting edge, it's a way forward. In another way, within the observatory, we need to make sure that doesn't lead to an increase in inequalities, in the sense that, you know, people have access in whatever platform or means that they need. And I think about my 73-year-old mum, who's first generation Pakistani, first language isn't English, doesn't own a mobile phone, and wouldn't know how to access a computer or laptop or tablet or anything, and would not be able to, on her own, would not be able to consult with her clinician or GP remotely through digital means. And so we need to make sure that, of course, we look after those that are that need the extra support and are potentially vulnerable, but empower them in a way that we can as well. So we need to keep all those kind of issues and points in mind as we move forward.
That's right. Thank you very much for that. At the beginning, like I mentioned, we put up an infographic. I think the next question refers to the infographic, where she asks, are these data that the NHS Health Observatory being taken seriously by the trusts? What are the next plans from them? So what are the next plans from the data? We know about the data. Yeah.
Yeah, I mean, this isn't about what people say. It's about what people do, and that's absolutely critical, that we ensure that inequalities are addressed, not just by words but by deeds and action. And it's not just hospitals that need to take this seriously. It's, you know, we need to mobilize kind of society as a whole. And one of the things that that we're often reminded of within the observatory by our board members is the wider determinants of health. And like I mentioned before, of course, you know, the NHS has a role to play in putting out these kinds of statistics, but of course other parts of society need to play their role in that as well. It's you know, within the observatory, we're working very closely with hospital trusts and different parts of the NHS and the emerging healthcare architecture, but we're also working with within the observatory, we're working with the Department of Health and Social Care, with the Cabinet Office, and with Number 10 as well around some of these areas. And it was fantastic to announce, as the Department of Health and Number 10 did in June, of the twinning relationship between the observatory and the Center for Disease Control and Prevention in the US. And that was on the back of the G7 summit and the meeting between Joe Biden and Boris Johnson. And that is the level at which not just the observatory and the work of the observatory, but this agenda is being taken seriously. And I've mentioned the speech that the Secretary of State for Health and Care gave around racial bias in medical devices. Again, another firm example of focusing on this agenda at the highest level, and that will of course filter down through the implementation or the design and implementation of policies on the ground.
Okay, thank you very much for that, Dr. Naqvi. The next question, I think, relates to the question I was going to ask on the schedule. So I'll just ask that question and then refer to the comments in the chat box. So it's what can we do to change the narrative of definite but insufficient progress towards racial health equity? So it's always, the story is always, yes, there's progress, but the progress is not enough. So someone's put in the chat, she's a midwife, and she says that the stats have been the same for years and years. The media gets excited by them every time there's a new report published. But what are services actually going to do? In a way, this is important, she says, in a way that doesn't put the responsibility on women. She says it's more than cultural competency, training for staff. It's about systems that are set up to fail women who are not white. And that she feels too much responsibility on the woman to be more literate, more trusting of services and all that. So what's going to happen?
That's a good question, and I totally agree with the person that asked the question. Absolutely, and I think it goes back to some of the points I made. You know, this is about looking at the causes of the causes. This is about the biases that we have in our policies and processes and structures and the way that the healthcare system has been set up. And so, what is it that we need to do? Well, I think the first step to any level of change is to acknowledge that there's a problem. Within the NHS, I think that happened last year when the Observatory was announced and set up. So there was a recognition that there's an issue here. There was a recognition that actually something needs to be done from not just within the NHS, but critically so from outside of the NHS. And having worked in the NHS, at the heart of the NHS for 20 years, having had that kind of one step out of it now, working in the Observatory, which is a kind of a semi-independent organisation, I can see the value of an independent organisation that can hold up that mirror to the NHS, because no longer should we be in a position where organisations or systems are setting their own exam questions and marking their own exam paper on this. I think we need a real kind of wake-up call to this. And so there are a number of things that can happen at a practical level around this. Firstly, the importance of amplifying the narrative as to why this is critical. And when I talked about the patient outcome case, when I talked about the financial case, the legal case, the moral case, there's a reason for why we have the different cases, because this agenda, as I mentioned, shouldn't be one person's responsibility in an organization. And that's why having the different cases enables us to remind leaders around a boardroom, for example, where the decisions get made, that actually this is a responsibility of the finance director because of the financial case. This is the responsibility of the medical director, for the nursing director, for the comms director, and not just the equality and diversity lead that you may have in an organization, or the nominated NED within an organization that sits on the board. So it's really important that we focus on amplifying the narrative as to why this is important and critical. Secondly, it's about accountability. It's about holding organizations to account in a meaningful way and not just kind of in a tokenistic way. Yes, there need to be incentives, but there also need to be kind of those targets or those aspirational goals where organizations need to head to, and those need to be looked at from an objective accountability perspective. And we have regulators, of course, within the NHS that have been set up to do that work, but I think there's more work that those regulators can do in this space and should be doing in this space in terms of their own responsibility. And I know, as many others would in the NHS, if there's one thing that keeps chief executives awake at night, is what their regulatory rating will be. And so there's more work to be done there. But there's also the other end of accountability, which is individual accountability, individual responsibility in terms of what you do day in, day out, and your annual appraisal as a individual, whether you're a leader or not a leader. I think everyone's a leader in their own right. Your annual appraisal should focus on the level of progress that you've made on the equity agenda, whether that's to do with race, gender, disability, or any other characteristic given protection under the Equality Act. I think that's absolutely critical around the accountability. So that's the second bit. The third bit, I think, which is important, is the engagement bit. And I mentioned the financial savings, etc., around engagement. Engagement has to be absolutely critical. It cannot be people just sitting in the top office making decisions for the rest of the workforce or the population, very often those people sitting in the top of the office not being representative of those people or those communities. And that's absolutely critical that we have that level of engagement, that we have that level of representation at all levels as well. And then finally, related to that point, number 4, I think, is leadership. And we mentioned this point before because, you know, if we are to shift this agenda, we do need people, role models that are absolutely committed to this agenda and our allies. And I've been lucky enough in the NHS to be working with a lot of those allies, white allies as well, that are able to be comfortable with the uncomfortable around this agenda and be on that learning journey. You know, we cannot have a leader, or a person cannot be classified as a leader if that person only leads for some of the people, some of the time. We need people to lead all of the people all of the time. And that's absolutely critical if we are to shift that dial of inequity going forward. And as I mentioned before, this isn't just about what people say, it's about, you know, ensuring that inequalities are addressed by action. And by action, I mean not just focusing on surface level issues and putting a kind of a sticky plaster on those cracks that are you know, deep within our society, but really looking at focusing on those causes of the causes.
That's right. We don't put a band-aid on it, we fix it. That's right. Thanks a lot for that, Dr. Naqvi. At the beginning of the conversation, you shared with us some of the priorities and objectives of the RHO. You spoke about maternity, mental health, and a few others. Someone in the chat wants to know if unpaid BAME careers and disparities experienced by them is one of the things. Is this one of the things that the observatory is also engaged with? Being almost invisible, the lack of good mental health treatment. Lack of good mental health treatment by police, treatment by medical services. So he or she wants to know if this is or these are one of some of the things that the RHO is engaged with.
Yes, I mean, it's difficult for me to kind of roll out everything that we're doing. We are, so we started on the 1st of April this year. So we're kind of 6 months into, officially 6 months into our work program. We are focused on, as I mentioned, some of the deep-seated issues that we have around mental health, as the person mentioned, around maternity, around digital health, etc. But we are also interested in things that kind of are emerging as well. And we know of the very sad deaths this year, early on this year, of young Black people from sickle cell who were not able to receive their care in a timely way, which has spurred certainly us on to think about what is it that we can do in the sickle cell disease space, which I guess arguably has become the poor relation when it comes to focusing on health, ethnic health inequalities of late. I think the spotlight has been slightly taken away from that. There's more work to do, and we're certainly focusing on that, and on mental health as well. It was just last week that we issued a tender for research to help us look at reviewing the IAPT program, the Access to Psychological Therapies national program, which was rolled out 13 years ago. This will be, through the Observatory, the first ever independent review of the IAPT program from a race ethnicity angle, and we will look at what is it that needs to be done to improve kind of psychological therapies. So there is a lot of work that needs to be done, not just with us and not just with the healthcare sector, but beyond that as well. So, you know, I think crime and policing, housing, education, diversifying education and research is another area that we are particularly interested in. And that's not just looking at representation in terms of ethnic minority participants in research, but representation in terms of who leads the research within academia and beyond, who wins the research awards. So we are liaising with the relevant research bodies around that specific area as well.
Okay, thank you very much, Dr. Naqvi. You mentioned about leading research, but a few people in the chat are concerned about the participants. So they want to know what the RHO is doing about ensuring that the research participants are representative.
Yeah, it's I mean, I've given a couple of examples of where we have interventions and devices that are potentially biased as a result of the lack of representation. So that's critical for us. We've had initial conversations with a number of bodies, including the National Institute for Healthcare Research, the NIHR, around what is it that we can do in this particular space in terms of putting in, for example, putting in criteria within the awarding of research and various other kind of grants, etc. So there is work that is ongoing at the moment with regards to that, and it is one of our key priorities. Okay,
thank you. And we're just wrapping this up now. Someone else would like to know if the observatory is empowered to enforce changes, or do you just raise awareness? Can you actually enforce change as well in the RHO?
Yeah, that's a really good question. The impact of what we do will be seen in a number of different ways. One of which will be policy, one of which will be kind of leadership focus on this agenda. I can give you the example of racial bias in pulse oximetry because that's been the first piece of work that we've done since our establishment in April of this year, and I can say that that has led to impact in the sense that we had 3 recommendations in our report around pulse oximetry. There was one recommendation for the NHS around updating its guidance, which it has done on the NHS Choices website. There was one recommendation for the NIHR around research in this area. And I know from recent correspondence that the NIHR is looking into pushing out calls for further research in this area. So we are able to prioritize research priorities as a result of our work and impact. And then in terms of leadership, I mentioned the speech from the Secretary of State for Health and Social Care, Sajid Javid, where one of his key focal points in his speech was around racial bias in pulse oximetry and medical devices, and how we are now engaging with the Department of Health and Social Care on looking at how we take that forward. Potentially, I have to say, in collaboration with other countries as well. So that's the kind of level of impact that we can have. We are close enough to the NHS to have, to impact upon some of the nuances around policy, but we are also distant enough to be kind of seen to be independent and to work kind of independently as well.
Okay. Thank you very much. So finally, looking to the future now, do you think our children can look forward to and enjoy social justice as UK citizens? Can we say that they would enjoy a healthy future?
Well, we have to be positive, I think, and we have to, as we have been doing over the last 18 months, learn lessons from the past. Yeah. And, our progress will depend upon that moral compass for all pointing in the right direction. And, we all have a role to play in closing down the gap between the promise of our values and ideals and the reality of our time. And that reality of our time is the stratification that we see within society. Very often, in this case, based upon the color of your skin. And if we can close down that gap by focusing on the right things, on the right issues, in the right way, collaboratively, then I'm very optimistic that the next generation and generations to come will be living in a more equitable society than the one that we live in today, and of course the societies that have gone before us, and the decades and time that has gone before us.
Sure. Thank you very much, Dr. Naqvi. Really, really grateful. And thanks for the questions that have been answered. Thanks to everyone who posted questions in the chat as well. I'll now call on my colleague, Professor Gina, to round up the conversation.
Habib, thank you so much for sharing your precious time with us today. We do realise that you have an enormously hectic schedule in your work as director, and this session has been absolutely fantastic. I have thoroughly enjoyed it myself, and I do hope that the participants who have joined today have really gained from the fantastic information and evidence that you have shared today. It's been hugely valuable and provided us with critical and important insights into the functioning of the Race and Health Observatory, and indeed the national agenda in relation to addressing health inequalities in respect of our communities here in England. We really do applaud you for your endeavours, because there is an urgent need to address these profound health inequalities, and we do indeed sincerely hope that our children and our grandchildren will experience social justice and equity in respect of their health experience and health status in future decades. Thank you once again, Habib, for engaging with us in conversation today. I know it's been intense, it's been a long period of time, but you are deeply knowledgeable about your topic.
No, thank you so much, Gina, as well, and thank you to the University of Nottingham, to colleagues I've organised this event. I think it's really important for us to have these kinds of events, and of course not just during Black History Month, but throughout the year. It's absolutely essential that we have these. And thank you also, Gina, for your ongoing invaluable contribution within the observatory. So when you say, you know, we need to kind of applaud the observatory, I think that includes yourself as well, because, you know, your work is invaluable particularly in the maternity health space as well. So thank you for that.
Thank you very much, Habib. But I would also like to thank Dr. Maria Arruda and Dr. Ikhile for their participation in planning this event, because their inputs have been absolutely superlative. You did an amazing job in briefing us, managing the technical aspects. Everything has run perfectly. Thank you, Maria, and thank you, Ife. And I'm going to leave you now, and I hope everyone has had a fantastic, engaging event this afternoon. Thank you so much. I don't know if Habib is still here.
I am. Yeah, I'm still here.
Wow,
thank you so much. That was so well organised, and thank you, Dr. Ikhile, for the chairing of the question and answer session. I thought that was fantastic. It was really important questions.
Yeah, you did a brilliant job, Ife. You did it so well.
Absolutely.
Thank you. Thanks, everyone.
Habib, the comments in the comments box, we must get the transcript for you, because they are absolutely fantastic. It's been very, very well received. I'm so happy.